Welcome everyone. I'm Maggie Pocella from the Genetic Sciences Division at Thermo Fisher Scientific. Thank you so much for joining us today for our presentation titled Contribution of Chromosomal Microarrays in Precision Medicine for the Clinical Laboratory. It's my pleasure to introduce you to Dr. Lea Menair, who's the Division Director of Molecular Pathology and Cytogenetics within the Department of Pathology at Hartford Hospital-Hartford Healthcare. Dr. Mnayer and her team provide molecular pathology and cytogenetics testing services for the entire Hartford Healthcare hospital system and the Connecticut Children's Medical Center. She has designed, developed, and clinically validated numerous molecular cytogenetic assays and has extensive expertise in test design, interpretation, and reporting. For a complete biography on our speaker, please visit the tab at the top of your screen. If any questions arise during this presentation, we encourage you to submit your Q&A in the Q&A box. Our speaker will address your questions following this presentation. As a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits tab located at the top right corner of this presentation window and follow the process to obtain your credits. For now, we'll turn this over to Dr. Mnayer. Thank you so much.
Hi, so this is my title, and these are my disclosures. So microarray analysis detects copy number changes, which have emerged as a component of precision medicine. Copy number changes can also represent a responsive biomarker to targeted therapy. Copy number changes have also been implicated as biomarkers in therapy resistance. They are also of prognostic value, and they can be also used to distinguish between benign versus malignant tumors. So the microarrays are an important part of an integral part of the molecular pathology and cytogenetics lab menu at Hartford Healthcare. So microarray testing has applications in both solid tumors and hematopathology. We offer the arrays as standalone assays and also as part of the workup of a certain tumor. Also, we offer that as a reflex to a karyotype or FISH testing. In this presentation, I'll be describing the uses of microarray in our clinical lab that has extensive test menu and explaining how it fits among the services that we currently provide. So the molecular pathology and cytogenomics labs at Hartford Healthcare provide full services in molecular pathology. And at this time, we continue to offer standalone assays in BRAF, EGFR, and KRAS. We continue to maintain those for the sake of a quick turnaround time. We also have applications in Sanger sequencing as well as fragment analysis, which we use the API system for these. In the past few years, we have moved heavily towards next generation sequencing, and at this time for solid tumors, we carry 3 NGS panels. We have a 99 gene DNA-based panel that we custom designed. And we offered this in combination with another custom designed 64 gene RNA-based fusion panel. We offered those combined in combination for lung, colorectal, breast, thyroid, endometrial, ovarian, and other cancers. For the sarcoma, similarly, we used the 99 gene DNA-based panel along with an off-the-shelf 26 gene RNA based fusion panel specifically targeting sarcomas. This was off the shelf from Archer DX. The molecular pathology labs at Hartford Healthcare also provide full service test menu for hematopathology, and among an extensive menu of standalone assays that we offer in HemePath, We also offer, we carry a 75 gene DNA myeloid panel, NGS panel. We also have a custom designed 170 gene DNA based lymphoid panel, and as well as a 205 genes RNA-based fusion panel with applications in myeloid and lymphoid malignancies. The labs are also full-service cytogenetics labs. We used karyotyping that applied to multiple sample types. We have an extensive FISH menu with FISH probes used on peripheral blood, bone marrow, lymph nodes, cell pellets, FFPEs, and others. Microarray testing has also been validated to run peripheral blood, bone marrow, FFPEs, products of conception, lymph nodes, and other specimen types. I'm going to start with a well-known biomarker that is of diagnostic and therapeutic importance. It's the KIAA1549 BRAF fusion. And this fusion is frequently associated with cerebellar midline pilocytic astrocytoma, which is a subtype of pediatric low-grade gliomas. And we see those in 60 to 80% of this tissue type. These are activating fusions and that activate the MAP kinase pathway. Patients with this fusion are responsive for treatment with sorafenib, which is a multi-kinase inhibitor. These tumors are resistant to vemurafenib and dabrafenib. This fusion is also responsive to a number of compounds that are currently in clinical trials. And also it's responsive to MEK inhibitors. These are recent MEK inhibitors, cobimetinib and binimetinib. Combinatorial therapies of trametinib or binimetinib in combination with the mTOR inhibitor everolimus have been shown effective for the KIAA1549 BRAF mutant brain tumors. With this fusion, there's a duplication associated with this fusion, and it has been our only marker for the longest time for us to be able to characterize and to select those patients that have this fusion translocation for targeted therapies. So this is the duplication as it's visualized by the array. It's a 1.9 to 2 mega base fusion that maps to the long arm of chromosome 7, band Q34, and this is how it's visualized by the array when you zoom in, showing the characteristic duplication. And this is a zoom in at the duplication and then showing where the KIAA1549 and the BRAF are located at the ends of this duplication. And this is how it's visualized using the fusion assay that we currently also use in combination with the array. The arrays are also used as to identify certain diagnostic genomic profiles. So for example, Burkitt-like lymphoma that has characteristic 11q aberrations. This is a new entity of a germinal center-derived, highly aggressive B-cell lymphoma that has recently been recognized in the WHO of 2017 classification. This diagnosis, as recommended by the WHO, should be considered in patients with high-grade B-cell non-Hodgkin's lymphomas that lack the c-MEK gene rearrangement. This is a figure. This is actually our figure that is showing the morphology and the stains, and then as well as the characteristic genomic profile. It's a characteristic rearrangement or duplication and terminal deletion in chromosome 11 This is our figure. As I mentioned, it was selected for the journal cover from an article that we submitted. The microarray analysis of those lymph nodes should be done on the involved lymphoids, and these tumors, they show a proximal gain of 11q followed by a terminal deletion, and this is pretty characteristic of this category. And this is actually a more recent case. This is a 65 years old male that presented with severe abdominal pain and rapidly growing mesenteric masses and bulky lymphadenopathy. By flow, the abnormal cells were positive for CD19, 20, and 10, and were lambda restricted. By FISH, we found out that the patient, that the lymph node or the tumor cells were negative for BCL2, BCL6, and c-MYC. The microarray showed the proximal gain of 11q, and then along with the terminal deletion of 11q. And so this case was characterized as, or like diagnosed as Burkitt-like lymphoma. Another application of the microarrays is the identification of certain variations, such as the amplification of FGFR1 gene is a marker of targeted therapy or therapy resistance in general. So this is an example. This is a case, 81 years old male, that had a history of diabetes mellitus, COPD, and a history, was diagnosed with non-small cell lung cancer in July 2019, but then recently presented with a lung mass and a liver mass, and then was diagnosed, was found to have metastatic non-small cell lung cancer, and then FGFR1 gene amplification. So this is, as I mentioned, is a mechanism of treatment resistance. This is the genomic profile by the array of the case, and this is the chromosome number 8, showing where FGFR1 amplification was identified. And the array recorded or identified 32 copies of the FGFR1 gene, and this correlated with the finding by NGS, which identified a 16-fold change, copy number change, which corresponds to 32 copies in total. We also use the arrays in difficult scenarios or equivocal scenarios with the HER2 breast cancer. This is HER2 is the human epidermal growth factor receptor 2, is a valuable prognostic and predictive biomarker in breast cancer. And the accurate assessment of HER2 status is essential in selecting the patients with invasive breast cancer who will likely respond for HER2 targeted therapies. So we use, in our lab, we use the FDA-approved PathVision, Abbott, the FISH assay, and then we reflex that to an equivocal cases by IHC, having +2 by IHC, and then according to the new guidelines by the ASCO CAP of 2018, these were revised guidelines that determined that HER2, the ratio of HER2 CYP17 of equal to 2 or higher is considered as amplified. So this is an example of such a case where the arrays helped us determine and then be confident about the call. So this is a 74 years old female. The surgical pathology report looked at a left breast mass, and then it was diagnosed as an invasive ductal carcinoma, high grade. IHC HER2 was equivocal, +2 with heterogeneity, and then the FISH HER2 was applied, and then we had a HER2 CEP12 ratio of 2.67. So we were a little bit we were kind of worried about calling this amplified because it's very close to the cutoff. So we ended up running it on the array, and this was the genomic profile identified by the array. So there were multiple copy number changes, and then this is where the HER2 resides on the long arm of chromosome 17, and this is where the HER2 is, and then the array identified a copy number of 3, and then we were confident at this time to call it as HER2 amplified. This is another case, lung adenocarcinoma. This is a 58 years old female diagnosed in 2018 with EGFR mutant lung adenocarcinoma. And then at that time, the patient was found to have an activating mutation in the EGFR, the L858R. So the patient was started on Tarceva, imatinib, afatinib, and then the patient continued to respond until recently. Very recently, the patient progressed with brain metastasis, and tumor resection was performed, and we were given sections from the tumor. A tumor cellularity of 70% was given to us. So we ran as part of the workup, a microarray was ordered. We ran the array, and as you can see, there is quite a bit of copy number gains. And among the copy number gain, there was a number gain of MET, the MET gene, that maps to the long arm of chromosome 7. And as you can see by the array identified the copy number gain. And then similarly, the copy number gain was identified by NGS, and 14 copies of the MET were detected. And MET gene amplification is a method or is a mechanism of targeted therapy resistance. And then this is pretty much what we've done for the case. We also use the arrays to rule out hidden hypodiploidy that is a high risk finding in acute lymphoblastic leukemia. And according to the COG, we are it's indicated that you run an array to rule out endoreduplication or hypodiploidy whenever you see tetrasomies or multiple chromosomes that are tetrasomic. But this is a case that had trisomy, was near triploidy. And then, however, when we ran the array, it identified a hypodiploidy, which is a high risk finding in B lymphoblastic leukemia. So this is an example, another example how we utilize the arrays in our lab. We also use it to determine tumor relatedness. This is an example of a 38 years old male that was recently diagnosed with testicular carcinoma. And then very recently was found to have a liver mass that was, the histology was neuroendocrine tumor, and there was a question if this was a metastasis from the prostate tumor. So the array was ordered, and as you can see, it shows that there is marked difference from the testicle, and then as a result, it was determined that this is a newly arising tumor independent from the tumor that was seen in the testicle. It's also used, the arrays are also used to determine risk evaluation and for tumor staging. This is an example of Wilms tumor, metastatic nephroblastoma. The array was performed on a lung lesion. And then this is the deletion that is associated with Wilms tumor, where there is a deletion of 15 megabase of including or of the region of the WT1 gene. And then the array also identified a duplication of 1q and loss of heterozygosity of 1p. Although the histology have determined that this is favorable histology, the array is indicated for such cases, and then the association, and then this is an article that shows and that how this finding of duplication of 1q along with lots of heterozygosity of the 1p is considered as an inferior survival marker, and it changes the prognostication of this case. So this is another indication or another application of the arrays. Other additional scenarios where microarray testing is applicable, we apply microarrays to all brain tumors, and for example, the things that we look for in glioblastoma multiforme, EGFR gene amplification is clinically relevant and is a targetable finding. We also use the arrays on liposarcoma versus lipoma. We look for MDM2 gene amplifications and other findings. With POCs, we routinely apply the arrays whenever the cytogenetics, routine cytogenetics yields a 46XX. This is an example of a POC that gave a 46XX by karyotype. However, when we performed the array, there was a trisomy, a gain of chromosome 14, trisomy 14, and then because of the maternal cell contamination, there was the baby or the POC is male, but then because of the maternal cell contamination, the array gave this profile. And you can, when looking at the tracks, you can identify chimerism all over the genome. And then last and not least, I want to thank the team of people who work relentlessly on bringing this line of testing to our patients, oncologists, and pathologists. And thank you for your attention.
Thank you so much, Laila. I really appreciate that. We have a couple of minutes to take some questions. So we're going to move into our Q&A portion of this. As a reminder, you can submit your questions via the Q&A box, and any that we don't get to today, we will answer on email. So Dr. Mnayer, the first question I have here is about NGS and microarrays and using them. So how do you decide when to use NGS and when to use microarray?
Well, the decision is made partly by the oncologists and the pathologists, and partly by us, depending on on which other tests have been performed on the case. For example, if we see a FISH result, and then so that's when we determine that maybe we need an array on the case. As I showed you in the POCs, whenever we have a 46XX, we go right away ahead because the requisition forms say to be reflex to array should a 46XX is found. With brain tumors, it's part of the workup. Whenever we get a brain case, it's part of the workup. It's right away we run the array. In case of lipoma and liposarcoma, MDM2 gene amplification, sometimes we run the FISH, but then other times the oncologist and the pathologist would like to see an array to see if there are extensive structural rearrangements or other things going on.
Thank you. That's very helpful.
Yeah.
So I have another question here, and you mentioned FISH. So in regards to that, have you seen any discrepancies between FISH, HER2, and microarray testing?
Whenever the tumor cellularity is adequate, And then we try to correct for the tumor cellularity on the array and on NGS. There has not been any discrepancies. As a matter of fact, the array has been very useful in helping us decide on those at the cutoff cases when you feel unease of calling it amplified or non-amplified by FISH. And especially when there is tumor heterogeneity, when there are like certain areas that appear to be a little bit like high, but then this has been like a very useful tool.
Thank you. So we have one more, maybe two more times for about two more questions, I think. So I have one here about one of the cases you talked about. Do you always run a microarray for c-Myc, BCL2, and BCL6 negative B-cell lymphoma?
We now once the because if it is an aggressive lymphoma, diffuse large B-cell lymphoma, and then we get negative by c-Myc, BCL2, BCL6, and IRF4. So we now, this is in our workflow, we run the array to rule out a Burkitt light.
Okay, great, thank you. And we have time for one more question. So this one is come in and it says, what is the minimum tumor cellularity that you accept for microarray testing?
Because the tumor cellularity is an estimate, it's not always accurate. So sometimes we can run the array at 10%, 10 to 15%. We prefer the 20%, but then because of the variation in the estimated tumor cellularity, we can run it at 10%.
Thank you so much. So it looks like that is all we have time for today, excuse me. As a reminder though, again, any questions that you submitted today for Dr. Mnayer that were not answered, we will address via email. So please keep those coming in and thank you. Thank you again, Dr. Mnayer, for joining me, and thank you for the audience for all your participation. Don't miss out on all the other valuable presentations around this virtual event. You can visit the agenda tab in the auditorium for a full listing. And to learn more about our chromosomal microarrays for oncology applications, please visit the microarray analysis booth in the exhibit hall, or you can click on the red Request More information button throughout our virtual event. Lastly, this presentation that you saw today will be available on demand on LabRoots through September 30th, 2021. Please go ahead and share it with any colleagues that might be interested. Thanks again so much, Dr. Mnayer, and thank you for the audience for your participation. Have a great day.
You're welcome. Thank you for having me.